Hi everyone, just wanted to go through some info from last week and give you a brief overview of this week to come. So last week we talked a bit about, hopefully you can't hear my cat chomping on treats in the background. If you can, I apologize. He's right behind my computer. So last week we talked a bit about the Colorado Accountable Care Collaborative to go over some of the barriers to the implementation of their planning and needs assessment. So that was an interesting discussion. So I'm just going to flip over to that document here pretty quick here. Let's see. So obviously some of the key themes they were presented right in the document, but we did have some more slightly more in-depth discussion about what those themes are. And I think that some of the issues surrounding that were, obviously the carve-outs related to behavioral health, contracting with, what's an issue with contracting. Obviously you can sign a contract with someone that has that technical expertise, but you need someone that also understands something more than just the technical aspects. So what is data going to do to make those changes in care delivery? So how finding someone that can manage not just the data, but can be a strong advocate in using that data to make changes in care delivery. So all of that is important. Obviously, the issues with relation to patients, and I know I had talked about this in the Flipgrid itself. Medicaid patients tend to be kind of migratory. They may come in and out of your Medicaid program, and then also they may be eligible, not eligible, eligible again, not eligible. So that causes issues in data as well. So all of that is problematic. This notion of attribution to a primary care doc was problematic. So that was significantly an issue under this particular program. And then just the notion that data analytics overall are fundamental to accountable care, and making sure that every player in the process was understanding of that. That kind of feeds down into that notion that I had mentioned before, that the contractors bought into that as well, that they were more than just someone pushing data, but that they were part of this accountable care process. So all major barriers. And I think that we had some good discussion about, how can we overcome some of these barriers, like behavioral health. That's a huge issue, that it's not just being faced in systems like this, but in all systems where behavioral health data isn't available to primary care. Yet in many situations, primary care is being expected to provide, not just accessory care to the behavioral health services, but in some cases they're being asked to provide medication management in assistance to perhaps counseling services being provided by social work or psychologists. And it's hard when those primary care docs cannot see the information that those other providers are, the documentation those other providers are documenting. So it's this notion of non-connected medical records and the special protections that are put on various types of behavioral health records, which rightfully so they should be, but there are certain situations where from a continuity of care standpoint, we really need to open up some of that documentation so that it can be brought together. And this notion of the attribution of Medicaid beneficiaries, that to me is just insanity. You can't just attribute a patient to a physician based on where they lived or where they had been seen 2 years ago, 5 years ago. That was just craziness. So that whole situation needed to be adjusted as well. And that's where sometimes data is great, but it needs to be used in an intelligent way and not just, you can't just crunch data for data's sake. You need to use it in an intelligent way. So, so lots of good information, interesting, certainly an interesting approach. And this is where, accountable care is great. I think it's an excellent way to, accountable care systems are very interesting, and I think that they're very important to, accountable care organizations can be very effective if everybody buys in, including the providers, the payers involved. The whole system works together, uses data to appropriately treat patients, etc. And it seems like this particular system was more of a, okay, let's just use data. And there wasn't as much actionable data being used throughout. Now, perhaps that's just what the focus of this issue brief was, and we didn't see as much of how it trickled down to the provider level. But I think it can be very effective if it goes down through, but it's hard to say. So interesting stuff nonetheless, and I think it's good for us to take a look at that kind of information. So last week we also had our infographic. Last night we had some wonderful presentations from everybody about their infographics on community health assessments. A lot of folks used different community health assessments from facilities in the area or around the area, which was great. As you may or may not know, I think the majority of you are aware, community health assessments used to be very common in the public health world, and you would find them being done by county health departments, etc. But under the Affordable Care Act, it became a requirement for any nonprofit hospital to do a community health assessment once every 3 years. So it is now a requirement for any hospital that's not for profit to do these community health assessments. And we had a short discussion about it last night that some hospitals put a lot of effort into it to really, and there are certain requirements. There are IRS requirements because it's part of remaining not for profit. So they are IRS requirements. But there are certain requirements. Some people go all out and put a lot of work into it. Some people do the minimum, so because it's a requirement. Some people are right in the middle. I think most people are right in the middle. But we had some presentations last night where it seemed that they were really more on the further end. I think it was McKeesport really seemed to put a lot of effort into it and really kind of went all out to work with their community partners. And that's really what it's supposed to be. You're supposed to be working with your community partners to see where are the gaps. Where can you work with your community partners to better, to assess health in your community so that you can better health of your population. And then I think we saw on the other end that there were some that were really not doing a lot. And then we saw some that were kind of in the middle, taking data from the county and crunching that data and then applying it to their population. I think that's what most folks are doing because it, as I had mentioned last night, so many times these regulations that we get from the government are what are known as an unfunded mandate in that okay, do all this stuff, which is going to take you massive amounts of time. We're not going to give you any extra money to do it. And it's a requirement. You've got to do it. You've got to post it up on your website for the world to see. And that's it. We're not going to pay you anymore. But if you don't do it, you're going to have to pay a $50,000 fine. So it's very difficult to want to put a lot of effort into it. Outside of the notion of ultimately it could really help our population. So that's, I'm looking forward to hearing the rest of the community health assessments tonight at our next synchronous session. So one last thing before we go. week 5. So this week we're talking a little bit more about ACOs, accountable care organizations, and how important they are. Obviously, we had our synchronous session, but also what I'm hoping is that everyone can find a great success story from this website about how the other thing we're talking about is, again, some more of that integration between public health and primary care. So I'm hoping that you can find from this site one of the success stories that's noted there, and you will be able to find the any issues that were discuss the issue that was addressed, find any limitations that were faced, and what was the integration that helped to improve the experience for patients, better the overall health, lower the cost of care, whatever it happened to be in that particular situation. Now you'll see here these are the directions for the particular case that we're doing. Here is where you'll submit it. Because with the Turnitin instructional box here, I was unable to put the link. So, these are your directions, and down here is where you'll submit that assignment. Also, this week you'll be submitting your topic choice for your final project. You don't need, obviously this week you're not submitting your paper, you're just submitting your topic choice. So what is it that, just a paragraph about what it is that you want to talk about in your final paper, which is due in week 7. So I think that's all I've got this week. Hopefully everyone has a wonderful Thanksgiving. And I mentioned this last night, I'll mention it again tonight, I'm sure. But if you do have to work on Thanksgiving, I know a lot of you work in clinical settings. So if you do have to work on Thanksgiving, thank you for doing that for us. I have never been in a situation where I had to work on Thanksgiving or on holidays, but my husband has for many, many years. This is the first year that we haven't had to worry about that, so it's kind of nice. But we have had to always deal with that, so I'm glad to have him home. So if you do have to work on Thanksgiving, I hope that you're able to find some time to celebrate with your friends and family at some point this week. So everyone have a happy Thanksgiving, and any questions, please just let me know. Thanks.